Thank you so much. I hope you can see the slide and hear me clearly.
Very well.
I will indeed start, maybe to zoom out a little, and this incredible meeting and all the brilliant minds of the Human Brain Project trying to model consciousness, where I would maybe propose that now is also the time to try and translate this brilliant science to better care. And that I believe we are now, with all the partners, in a position to start thinking about how this modeling of human consciousness in both pathological alterations, and Melanie just gave us a nice overview, or the pharmacological modifications we see in anesthesia, but also physiological, not just sleep, but I believe also the added value of hypnotic state and meditation. And that, of course, with all these state-of-the-art technologies, multimodal, as we have seen with MRI and positron emission tomography, which I think when we inject radioactively labeled glucose is still one of the most direct markers of synaptic activity, and then the dynamics captured by high-density EEG. And I, again, want to use this opportunity to thank the wonderful collaborations. We see here a picture of Marcello Massimini and the EEG net, and it's been a pleasure to collaborate. You know about the EEG TMS studies and how that is being translated to the clinical reality. Also, of course, the expertise, people like Gustavo Deco from Barcelona, and the ethical consequences with our partners from Uppsala, and that's what we will be discussing later today. But I would like to turn this around and start by reflecting on what are actually the needs of patients and their families in Europe. So trying to zoom out here, and you all have all your scientific knowledge, but maybe it is good to remind ourselves what is the reality of patients and families confronted to these devastating conditions after traumatic brain injury, bleeding, cardiac arrest survivors. So this is what we did, work with Olivia Gossery, also part of a foundation I created, MindCare International Foundation, where the aim is exactly that. It is trying to answer the need of those who are confronted to coma and chronic disorders of consciousness. And that's what we did with this questionnaire. We will ask them, hundreds of families, what is important for you? And it turns out they want to be informed. They are in a good position to know that we are still, despite current medical knowledge, confronted to uncertainty. Is there consciousness? Is there hope for recovery of consciousness? Prognostic uncertainty. And what can we do? Trying to translate again the knowledge to novel therapeutic options. So 99% of respondents said they need more information regarding these points. They want to be involved. 9 out of 10 families. They want social and emotional support. And then we asked, well, how are these important needs satisfied? And I think we can and should do better, because you see the numbers and they are not very good. So that is, I think, now that the Human Brain Project is being translated into structural e-brains, the challenge for us. And how do we model something we truly do not understand? And we shouldn't be too arrogant. We have no explanatory theory of consciousness. And yet at the bedside as a neurologist, I'm trying to do the best I can to quantify the level of consciousness or wakefulness or arousal, and then the content of consciousness, awareness of your external environment, awareness of your internal thoughts. And we all know when we fall asleep that there's a relationship between the level and the content. And we are in deep sleep, our level of arousal goes down up to the point we lose awareness. And yet we know there's REM sleep and lucid dreaming and these extraordinary examples of how there can still be subjectivity, despite that from the outside the patient looks asleep, looks unconscious. And the same is probably true for coma, which is patients who can no longer be awakened, who by definition will keep their eyes closed even when we stimulate them with auditory or noxious stimulation. And that is also for pharmacological coma, anesthesia. We've been using a lot in the lab, propofol, xenon, and then we have ketamine. Already an interesting challenge of our notion that maybe is a bit too binary. We are conscious or we're not. We're aroused or we're asleep. We're aware or we're not. And that is probably wrong. We should think in 50 shades of gray when it comes to the components, and probably not even collapse them in one dimension. And probably it's multidimensional, and all the colors of the rainbow represent here our subjectivity. And ketamine is one drug that will reduce arousal, and yet you can have some subjectivity, some awareness. And a very challenging entity, and I heard you use the name vegetative state, which is, I think, a term that we should avoid. For the past 25 years, being confronted to patients and seeing them die and seeing them recover and discuss with families, vegetative is not a term that we use anymore. It is being replaced now both by the American Academy of Neurology, European Academy of Neurology, by this descriptive neutral term, unresponsive wakefulness. That's what we see. Patients who survive their coma, yet they awaken, they open their eyes, but remain without a response to our commands. And this is challenging. It's a dissociation between the level and the content. We see automatic motor behavior, let no response to command. The same is true for sleepwalking. The same is true for some forms of epilepsy, absence seizures, complex partial seizures. And then the big challenge is to disentangle those patients who might have still some residual consciousness. We now call them MCS, minimally conscious state, minus when they show non-reflex movements such as visual pursuit, orientation to pain, or just patients who would show emotional reactions to the presence of a loved one, but that's all you got. And then there's MCS plus. The plus stands for recovery of response to command. And actually, a good example of how challenging it can be and how sometimes we can miss subjective awareness in a paralyzed body is locked-in syndrome, where patients classically communicate through movements of the eye. And then we have this new entity where only neuroimaging shows that there is probably a working brain and a working mind, and we call them MCS star. The star stands to the fact that it's only the neuroimaging technologies that permit us to see there's more going on. So this is kind of the trajectory of severe trauma or anoxia, the most frequent causes of coma in survivors who go through unresponsive wakefulness syndrome and then recover minimally conscious state, minus, plus, and emergence is defined by the recovery of functional communication. And as said, this novel entity where it's only the new technologies for MCS star that can identify the patients. How can we actually model this and help the technologies to reduce the diagnostic and prognostic uncertainty? It's a big challenge. It's a real proportion of patients. We really have no idea exactly how important the numbers, and we see a number of studies here published by our team, go from 42 to 67% of patients where we think at the bedside they are in a persistent vegetative state. Again, I will no longer use the term, it's unresponsive wakefulness, where historically we thought, well, there's nothing we can do for none of these patients. They'll always be a vegetable. And that is very probably untrue. We now see how the knowledge that the neuroimaging gives us clearly and repeatedly demonstrated that for some of these patients, not only is there consciousness, but also increased capacity for neuroplasticity and recovery. So this is the challenge. It's what we do with the Coma Science Group at the university in Liège, Belgium. It's trying to take those entities and do the best we can at the bedside with standardized behavioral scales. We'll come back to that, trying to identify not just overt signs of cognition, but also covered signs of cognition using functional MRI, PET, or EEG. It's very tricky. We can have both false positives and false negatives, and then there's all the major ethical implications. But I think it is worth trying together to improve the current clinical reality. And one paper, and I should be very careful because there's big experts in terms of machine learning, but this is a very nice collaboration between Olivia Gossery from our team and Professor Lee from Korea, using artificial intelligence and deep learning, where we have a data set also in collaboration with the team of Milano, EEG TMS, but also resting state EEG in sleep, in anesthesia, with ketamine, propofol, xenon, and then the coma survivors. And the results were here, the model was trained to score both dimensions, that is arousal on the x-axis and awareness, or the content of consciousness, on the y-axis. And you see the result. There is this difference, especially for, you see here, P stands for the parietal areas that seem to contribute the most to the model's decision, and that goes in the line of what has been discussed previously. So clearly added value. You also see the stars, that's for the MCS stars, where we thought they were truly unresponsive, and yet the other neuroimaging results showed that there was still a functioning mind and brain, and also here the TMS EEG and the resting state EEG classified them correctly. You see them up there in the category of patients that were conscious. And we had similar results for sleep, and again, this dissociation when you look at REM sleep and non-REM sleep, and ketamine versus propofol. So I think very interesting. And the next step for us was to not just look at level and content and this relationship and the recovery trajectory we see after severe traumatic brain injury, but also to separate the two components of awareness. And I think this makes sense because the data we've been acquiring over the past 2 decades now indeed show that we have this external awareness, everything coming into your senses, and the critical frontoparietal external awareness network. And then there's internal awareness, which is important for mind wandering, mental imagery, anticipating the future, thinking of your past. And that seems to critically depend on the internal awareness network, midline core, overlapping with the default mode network. And they show apparently an anti-correlation. And we know this from daily life. We go from being absorbed in our thoughts to being aware of what's happening around us. And meditation is a very interesting way to train that focus of attention from one to another. And hypnosis we have used in our hospital for now, again, decades, in over 15,000 patients who underwent surgery, including myself, in the database. And I think this is useful, and maybe also our partner within the Human Brain Project could try to challenge the current models with these data. In hypnosis, where you see here, it's different from just distraction. We see a state of absorption, of dissociation, where there's decreased external awareness. And we see with fMRI there's a breakdown of the external awareness network. And I think also part of HBP is to try to translate this into, again, clinical reality. And that is why we collaborate with industrial partners. And one of them is a Belgium startup, En Confort, using virtual reality to offer hypnosis to the widest possible clinical use, and again, validating that with modern neuroimaging techniques. Meditation is another fascinating field of research. We have no time to go into that, but clearly is its state where your level of arousal, we all know this iconic picture of this Buddhist monk putting himself to fire, and yet not moving an inch. So we've been studying these experts of the mind. For those interested, I wrote a popular book about this, also with Mathieu Ricard, who came as a guinea pig, and also with the Milano team, used EEG TMS to document what's going on. Another example is anesthesia, where this is the work led by Vincent Bonhomme, head of anesthesia in our university hospital, with many, many studies with different drugs showing the breakdown of external and internal awareness networks. So it's not happening in your sensory systems. They're, to me, slave systems. We see them still showing residual connectivity, both in visual, auditory areas. So they're necessary but not sufficient. And again, the challenge here, and this is another partner within HBP, Professor Nathan Intrater from Tel Aviv University, who created his own company, Neurosteer, taking that knowledge and using very simple, you see him here with this frontal EEG monitor system, and validating that in anesthesia as they are currently publishing. So again, the challenge to translate the latest science to clinical use through our industrial partners. Coming back to coma and chronic disorders of consciousness, this is a recent paper by the team, made the cover of Annals of Neurology, where we put together all the modalities, and that is both MRI, PET, and high-density EEG. And what you see on the cover is actually the functional connectivity in the different frequency bands, and you see how it differs between unresponsive wakefulness, minimally conscious state, control subjects, and then there are the MCS star, those who look unresponsive, and yet the EEG connectivity measures, but also the positron emission tomography, as you can see up here, shows different. And that was observed in 67% of the cases. And so this is not just a minority, it's not an exception, it is way more often than we think, and of course that has major implications. One of the implications is that we can try to establish functional communication, not only through the fMRI, and imagine playing tennis paradigm, which is very, very demanding. Patients need to come to an expert center and they cannot move, and we have over 60% of patients where this would just fail because of technical issues. So the challenge to use simpler EEG-based brain-computer interfaces, and again, the link with our partners, in this case GTEC from Austria, also within HBP, to offer this with a plug-and-play system. And a number of papers, including from Jitka Anand, showing that yes, these techniques have added value, but need to be confronted and cross-validated with the other neuroimaging modalities, which is what we do. And very often with these brain-computer interfaces, we would have no reliable response from the patient, no response to any of the commands, let alone functional communication. And there's many reasons for that, and one is probably that their level of consciousness arousal, but also the level of awareness is fluctuating. That's what we know as clinicians, that these patients are very frustrating, because you go into the room, you have maybe a sign, and then you come back an hour later and everything is gone. And that's why I think we need to more invest in the characterization of the temporal dynamics the Ultradian rhythmicity, where a paper by Andrea Piroli showed in MCS patients that there might be these windows of opportunity. So he showed if you just use a simple measure as spectral entropy, you see that every 70 minutes the entropy increases in patients who are MCS, and that's maybe the moment we should do the assessment. That's maybe the moment we should do the treatments, because we now have a number of therapeutic possibilities. Again, this is the work by Olivier Gaussery and Aurore Thibault. Olivier leading the pharmacological trials, very excited by the current results of the apomorphine trial. Aurore leading the TDCS and vagal nerve stimulation studies, where we are modeling the target of the Microcircuit hypothesis. And you see here the different arrows and the different clinical trials going on with our partners to try and change the trajectory of patients after severe brain injury. But again, let me come back to the start, the needs of families, and also the need to be able to help patients without the high tech. And that is why we developed the Simplified Evaluation of Consciousness Disorder Scale, the second, which we showed has added value. It is quick. It can be done not only by healthcare professionals, but we're currently showing that a very simple scale with just a limited number of observations can actually be also done by the family. You see here Dr. Sams, who just presented his PhD, made a video and offers really families to take a more central role in the assessment of patients, and that is what we're currently working on. So it's not only about the high tech, it's trying to empower also families and answer their needs that, as we said, currently remain unmet. That's it for me. I will let Jitka share her screen now, and we go back to some hard science and recent studies from Jitka and collaborators within the HBP. Thank you so much.